I became interested quite early on, thinking about how little we knew about what environmental pollutants could do to human health, and particularly to susceptible individuals and groups. But it wasn't until I was graduated from college and I actually had some young children that I became particularly concerned about risks to the very young from exposures even occurring in the womb or in early childhood. So it was, let's see, what year was it? In 1973. I saw a photo exhibition on the Minamata Bay mercury poisoning that occurred because people living around Minamata Bay in Japan who were subsistence fishermen, had the women who had been pregnant at the time, ate the fish, became, and their babies who were in utero at the time, were born with serious birth defects, cerebral palsy-like symptoms, mental retardation. And this, this photo essay was breathtaking in terms of how horrific the effects of this exposure could be. The mothers were not affected at the doses, even at these high exposure levels, but the fetus was. And that really triggered my concern. In those early years, I had been taking pre-med courses thinking I would go to medical school. And then I think after a good deal of thought and seeing this photo exhibition and other readings by Renee DuBose, Barbara Ward of the book One Earth, and other experiences, I decided I could do more if I had a degree in environmental health sciences and public health. Because at that point I realized that prevention was terribly important and that we weren't doing enough to prevent disease. So I came to the School of Public Health here at Columbia, got a master's degree, worked for a while in public interest, and then I came back for a doctorate. And at the time, I had already written co-authored a book on the effects of air pollution on human health, particulate air pollution, on human health and on the natural environment, including acid rain, and had become very frustrated during that experience by the lack of information on human health effects. The fact that researchers were relying on area-wide monitoring data, very sparse. They were trying to connect those types of data to deaths or serious disease incidents. And it was all very vague and at an ecological level. And I was interested in learning more about individual level effects and subgroup effects. And when I came back to do my doctoral work, I was lucky enough to hook up with a mentor, Dr. Bernard Weinstein, who was a molecular biologist and physician here at Columbia. And I came to him having read about the work in experimental systems that had been looking at the carcinogen DNA adducts formed in the laboratory from exposure to chemicals like the air pollutants I had been concerned about. Pollutants from the burning of fossil fuels, for example, called polycyclic aromatic hydrocarbons, big long word, PAH for short. And when I came to him, I said, what would be the possibility of working with you to take that particular method out of the laboratory and validate it in a human study. See if we could first detect those changes in DNA caused by chemicals, and if we could then go on to examine the relationship between those fingerprints, those molecular fingerprints, and disease, in this case, in lung cancer. And to my surprise, this molecular biologist, not epidemiologist, said, "I'm game," and he became my advisor. Over the next years, we worked together. I designed a study which allowed us to do that first work and to examine lung tissue and blood from people with and without lung cancer. And we reported that we were able to find this molecular change, or biomarker, we call it, carcinogen DNA adduct, formed when the chemical binds to DNA and leaves its trace. And that binding product can cause mutations, and ultimately down the road, certain things happen, cancer. And we were also able to show that there was a suggested link between the levels of that biomarker and cancer risk. So that was the first study of its type that had been done. That early study led to the development, and in fact, my colleague Bernie Weinstein and I proposed a conceptual framework where we used molecular epidemiology instead of epidemiology as a tool, where we incorporated these molecular markers to understand cause and effect relationships between environmental exposures on the one hand and health outcomes on the other, adverse health outcomes on the other. And the whole push for that was the need to prevent. We thought we could get early warning of risk before we had incident cases of serious disease or even deaths. So from the very start, my work and the work in this field of molecular epidemiology, which is what we practice here at the center, has been to be able to get the data, get the information early on, see the red flags in time to take preventive action and intervene. I went on with various colleagues and with Dr. Weinstein to further examine, validate that approach in worker populations and smokers, non-smokers, and then gradually got younger and younger in terms of my focus, looking at risks to preschool-aged children, for example, of secondhand smoke exposure. And then ultimately, as I was becoming aware that when we looked for a control tissue and analyzed some of the samples from, say, placental tissue or blood from the umbilical cord, we did find that there were often fairly high levels of this kind of damage, molecular damage, which should not have been there, right? Because we think of the fetus as in a pristine environment, protected from the world. So at that point, I realized that my focus should be on this particular stage of development, the fetal stage, where in fact, it was apparent that many chemicals were able to cross the placenta and reach the fetus, and that there was more and more evidence that there was greater susceptibility during this early stage, because the fetus, unlike the adult, doesn't have the immune defenses, doesn't have the DNA repair systems up and running, can't detoxify and clear chemicals the way adults do.